that was a good review. But
When we started doing revascularizations here and replantations back in the early 70s, Dr. Savison made a rule, if anything was involved above the knee, was done by vascular surgery. Below the knee, we could do it, microvascular team. Same with the upper extremity. Below the elbow, the microvascular team did it. If it was above the elbow, the vascular team would do the repair, not just the vessel repair, not none of the other stuff. They did not do that. But we didn't always go by that because many times the vascular team, the big vascular team would come in and they'd repair and do a graft, and I would take it down and do it over again about half the time. And a vascular problem below the ankle, should be done by the microvascular team. And John, you mentioned that they said it was irreparable distally. That's never the case. You can always go out further. We can reattach vessels distal to the nail plate. You can put the vessel into the vein if you have to, or inside of it. There's always something to find distally. So, there are 3 vessels going to the foot, and it looks like only one was possibly intact, or spasms, they say. Didn't know for sure. But the major one is the posterior tibial. So I think a definite effort has been made to graft there, or reconstruct it some way. So that should have been done. Then the foot may have survived. May have not still, but I think that every effort should have been made to reestablish the posterior tibial. You mentioned about the talus has been found and put back in 8 days. We had one time where a major bone from and a motorcycle accident was thrown out into the wood from the accident. It was retrieved by a dog, and we put it back in and did fine. True story.
So I think what this case points out to me is the difficulty with the consulting service gives you an order that says close observation for what essentially is an ischemic extremity. You guys did everything right. You said come back and see the patient. They kept coming back and saying, yeah, it's cold, it looks dead, keep a good eye on it. And I don't know what you could have done differently in the face of that, but I agree with Dr. O'Bannon. It probably should have been explored in some form or fashion if they wanted to keep the foot. But telling the service to keep a close eye on it without any other options, I think is a very poor consult.
Just given that you're dealing with fine vessel and they're calling it spasm, I would have imaged the chances of lifting an intimal flap that could partially occluded this and gone on to thrombosis, to my mind, is not unreasonable. And you're dealing with a foot that's ischemic anyways. And that might have forced your hand or their hand.
From what I understand, when they initially evaluated in the OR, there was consideration whether we need to transfer to another table for an angiogram, and it sounds like after the secondary evaluation, they were reassured and the decision was not made to perform an angiogram.
Ms. B was an 84-year-old female, had complaining of years of right hip pain. She had the noted drug allergies or adverse reactions to codeine and oxycodone. She has a history of major orthopedic surgeries that aren't presenting here, but she had a recent total knee arthroplasty done in 2013 that at the age of 82 that she tolerated well. She had spinal anesthesia with a femoral canal block, and she tolerated, she had no postoperative complications with the dilaudid PCA that was stopped on postoperative day 1, and transitioned to oral narcotics, and had an uneventful hospital stay, discharge on postoperative day 3. These were her preoperative films, and there was planned to do a right total hip arthroplasty. On August 13th, she underwent an uncomplicated right total hip arthroplasty. Her anesthesia consisted of a spinal block and fascia iliaca. That operative time was 73 minutes, and she was uneventful transferred to the PACU and then back up to the floor. This time we did PO pain regimen for her, as we've been doing on all of our joints patients. But specifically, Dr. Atarian had noted in his documentation that there was to be no long-acting narcotics or other medications that could potentially cloud the patient's judgment due to her age and her fall risk. However, on postoperative day 1, the patient awoke confused, thinking that it was the day actually before surgery. As she got up, she became tangled in her IV lines, taking a fall. She fell onto her right hip, noting immediate pain. She was evaluated by the overnight intern, where she was noted to be alert and oriented ×4. This was consistent except for this one short period of time for approximately 5 minutes. On exam, her leg was also noted to be externally rotated and shortened. She's distally neurovascularly intact. Of note, she had no narcotics overnight. She sustained the following fracture: metaphyseal, diaphyseal, periprosthetic fracture around the stem with subsidence and leg length discrepancy. A Vancouver B2, the acetabular component remained well fixed. Plans were made for that same day to go back with the operative joints team that day for femoral component exchange to a ZMR revision stem. Within surgery, the stem was grossly loose with extension of the fracture to the distal aspect of the femoral component. We then went on to reassemble the fracture with 4 Kinemed cerclage wires and then reamed up to the 15 millimeter diameter needed for the ZMR stem. After that, she was transferred to the floor. She had precautions of touchdown weight bearing with the anterior and posterior precautions, and she had an uneventful hospital stay from that point forward, being discharged post-op day 3 to Hillcrest, as she had with the prior orthopedic operations. The patient was seen 2 weeks post-operatively, noted to be doing well, with little pain. And then her last visit in October, the patient was transitioned to cane use and told that she could be weight-bearing as tolerated. Now, in December, she's currently living in Florida, where her and her husband reside during the winter. So the 3 issues that I'll be covering are postoperative falls, postoperative delirium, and then basic fixation for B2 fracture, Vancouver B2 fractures. So the CMC, or the Centers for Medicare and Medicaid Services, no longer reimburse hospitals for falls that occur inside the hospital that they deem could be prevented with evidence-based guidelines. Overall, there are 4 to 12 falls per 1,000 hospital inpatient days. This accounts for greater than $19 billion of medical costs. A third of these are non-fatal and result in fracture. This accounts for 61% of the costs. The most common fracture is a hip fracture with an average cost of $18,000. There are specific risk factors that are intrinsic and extrinsic. The intrinsic ones that we cannot change are age, sex, cognitive impairment, baseline restricted ADLs, and baseline fear of falling. And then the extrinsic ones that we can control is specifically the hospital environment, to include IV lines, Foley catheters, well-lit rooms, and providing patients and just making sure that patients have the appropriate eyewear during their hospital stay. Lastly, delirium is associated with 45% of the falls on orthopedic floors. There was a study by Gustafson that showed delirium prevention measures with preoperative geriatric assessments, oxygen therapy, and early surgery all help prevent postoperative complications, decreasing the overall delirium rate by 15% versus the control group. Acrometal, an orthopedic specific study, demonstrated that there's an average rate of 1% of the inpatient admissions that fall, or 2.5 per 1,000 musculoskeletal inpatient days. Most of these falls, they noted trends where most of these falls were not witnessed. Majority are related to the patient going to the bathroom, along with 66% of these occurring at night. Overall, 19% of these resulted in injury. Statistically significant risk factors for patients that would fall include patients with prolonged admission, women, and then age greater than 65. I highlighted here those that were associated with our patient. Next, talking about delirium. Delirium is specifically an acute disruption of consciousness or impairment of attention with a fluctuating course. There are numerous causes to include infection, endocrine, metabolic abnormalities, intoxication, pain, and medications. In the literature, this has been associated with orthopedic patients 18 to 50% of the time. There's a case control study at a New England Baptist looking at total joint patients specifically, where they adjusted for gender, preoperative alcohol use, and depression, that demonstrated specific links to post-op delirium with isoflurane as the anesthesia, and then new benzodiazepines being ordered in the inpatient hospitalization stay. However, Dilaudid and morphine were not linked to postoperative delirium and were stated to be good pain control measures for patients postoperatively. In discussing Vancouver classification, this is just a brief highlight of tables that all the residents have seen on ortho bullets. Our patient had a B2 fracture with a grossly loose stem and good bone stock. The gold standard has typically been an extensively porous, coated long stem that bypassed the fracture by at least 4 to 6 centimeters for interference fit. In a recent review this past August in the Yellow Journal, the emphasis was really placed on being prepared for a loose prosthesis regardless of the fracture type, if it's considered, even if it's a B1. At times it is impossible to determine whether the stem is going to be grossly loose based on radiographs and imaging alone. If a Vancouver B1 is suspected, thorough testing of the prosthesis bone interface through the fracture site to determine implant stability is measured. And however, there has been a shift of the paradigm of B2 fixation from the extensively porous coated stems to modular stems. Modular tapered stems allow for diaphyseal fixation, rotational stability through splines, and reduced risk of anterior perforation as seen prior with the straight long stems, and then independent control of anteversion. Furthermore, they have the advantage of obtaining stability of less than 4 centimeters distal with interference fit, and they can rely on rotational stability with the spline. So learning points from this case, was this an error in technique? The initial surgery and post-surgery, neither of which, this was an unfortunate case with the patient being confused with the correct medications being ordered post-operatively. Was this an error in judgment? No, the patient had not only tolerated prior major orthopedic procedures well without any complications, but the patient was independent, had more than adequate support at home with their husband, and had the correct indications for this patient receiving total hip were also considered. And how can we prevent this from occurring again? Just highlight the table that had already been reviewed, but really just the extrinsic factors of modifying the hospital environment of the patient, trying to make sure that there's adequate lighting and appropriate removal of IV lines and Foley catheters to prevent falls. These are my references, and I'll open this up to discussion.
So thanks, Travis. That's a great review. I personally think that the fall was not preventable unless we had someone at bedside 24 hours a day, which the hospital cannot afford to do. So certainly when a patient falls, you feel terrible about it, and then you wonder if there's something you could do. So I'll be curious to see what other people say. The economics of this are a little bit interesting. So I get reimbursed for the primary hip. Dr. Bolognese will be paid for the revision and fracture repair. The hospital just gets a single DRG payment. The patient was in the hospital 2 additional days. what was originally planned. And so rather than the hospital probably making a margin of about $500 profit on a Medicare primary care, with the revision and the extra days, the hospital loses $5,000 in this case. So that's probably the key, is that it's an expensive proposition. We always should do everything we can to prevent these types of complications.
There was a British study a few years ago. The only way to prevent these fractures is to put these little old ladies in hip pads like the football players wear. That's too expensive too, I guess.
Yes, that was a good presentation. The only thing I was going to add was, like David was saying, it's really interesting, is the scorecard for the hospital also, includes falls as one of our, sort of like, red, green, or yellow, whatever, what our scorecard is. Each cap scores everything. And obviously, it doesn't take much to, the number of falls you can have to be, compared to benchmark facilities is pretty low, right? So I think the biggest learning point here is, it is a big deal to sort of do everything you absolutely can to prevent the falls. And I agree with Davis. I'm not sure what more could have been done, but it does make sense that you have to be really looking out for people that are truly at risk. And do absolutely everything that you can and use in place to prevent it, because it creates a danger for the hospital, like Dave said, not just financially, but also if you look at sort of the balance scorecard for the hospital. Dave, I am right, isn't that on the balance scorecard?
Yeah, publicly reported.
Yeah.
Yeah, I think delirium is one of the scariest things for me. I sort of look forward to anybody over 80. And I don't really know what the percentages are, but I try to warn families that, it's not going to be weird if the patient's confused for a day or two. And yeah, I mean, it's like a little out of your control at that point. I think, going light on the sedating medications, oral only, I think, I'm not saying this would have changed anything, but the less connected to IVs and stuff we are, the less that would be an issue. And I think we're moving in that direction.